never still figured it out today. Did you get a public health award or an education award? I was totally confused by the whole thing. You deserve both, and it's just fantastic. So thanks, congratulations again for the great work you've done. So with the understanding that Peter does have a product that he sells, but none of that is going to show up in this talk. He's going to be talking about what he thinks are challenges in pediatric medical care. And but we just want to make sure that was out there. But this has nothing related to this at all as the course director. But Peter, you were trying to keep up with the Joneses here, meaning in this case Lovis, about the top 5 things, right? So can you give us what those top 5 challenges in pediatric medical care are? So welcome back to our stage, Dr. Peter Antevy.
Very hard to ever keep up with Dr. Corey Slovis, but thanks you again, Paul. Okay, good afternoon, everyone. We're gonna make a little bit of a cadence here. I want to get through this in I think I have 10 minutes. So, what are the top 5 EMS questions that I really get from colleagues, people in the audience that are really fun for me to answer and really trying to figure out myself? Let's go through them here. So, the disclosure again. So here are the 5. What's the best pediatric airway option? What should we use for pain control, seizure control? How should we treat hypoglycemia? And should we withhold fluids in kids? So we'll get to all of those, and we'll give you some nuances, so it's not just a straight up type of thing. So the best airway option, of course, I believe in, and I think most people do, that if you have a BVM, chest rise, you have good saturations, and you think you're ventilating the patient okay, stick with that. I'm a big fan of the supraglottic airways, which you've heard over the last couple of days. LMA, the King Tube, and the iGel, which I have all of those in use in my systems, and we'll talk about those a little further here in a minute. So, of course, you know the differences between the King and LMA versus the iGel is that the iGel does not require an inflation pressure. When you have the King, every size requires a different inflation pressure, and it adds a little bit of a wrinkle, although the King, I think, is very good, iGel as well. And again, the King has those 2 tubes, and the LMA has that, and the iGel does not. Now, the only issue with the iGel is that when you get to the smaller sizes for pediatrics, you don't have these 2 little green hooks. And what happens is that when you put an iGel in and it's seated, right, once you start pushing on the chest, the thing pops out. And it pops out just about that much, and now you're not ventilating the patient, and you don't know you're not doing that. So I tell my medics to push it back down, or even hold it down. The only way currently is to hold it down with tape. And so I asked my friends around the country, Mark Conrado, John Ling, and they use something called the NeoBar, where we just order these. They use it for the iGel and for all their ET tubes. It costs about $12 a piece. It's called a NeoBar, and you can put that on the face, and then you can tape down a tube or an iGel to it. Again, so the iGel folks say that they're hopefully going to make these straps for the pediatric patient, and they need to do that. The King Tube, again, this is done by some of my friends in Pittsburgh. It's really hard to screw the King Tube up. You just shove it in, and it goes in the right spot. So the King Tube is, as long as you size it right, it's really a great way of doing it. And it has a gastric port. You should make sure any supraglottic airway you use, like you heard yesterday, should have a glottic port, a gastric port. If it doesn't, change them out and get the gastric ports in there. The success rate is very high for those. Here's a study looking at DL, so direct laryngoscopy, versus putting in a King Tube. And you can see here on the left-hand side was direct laryngoscopy, and you can see on the right-hand side, you can see that with the King Tube, you're already ventilating for 100 seconds more adequately than you are with regular intubation. So there are advantages, for speed perspective, for the supraglottic airways. At the end of the day, BVM is still king. What about pain control? Here's a 5-year-old who fell while running. What do you use at your agency? Are you using things like morphine, fentanyl, or ketamine? What I'm challenging you with is that there's going to come a day very soon where if you document a pain score of greater than, let's say, 5, and you haven't given a dose of a pain medication, then you're not going to get paid appropriately because you haven't done the right thing. So we should document pain scores, and we should actually treat kids who are having pain, even if you're just, quote-unquote, 5 minutes away from the hospital. So there are incentives, and the hammer will come down at some point. Which medication should you use? So you have a choice of morphine, fentanyl, there's Dilaudid, and ketamine. I would say that fentanyl and ketamine are the leaders. Obviously, fentanyl is very fast on, and so is ketamine. Morphine, I'll show you the issue with morphine. If you can see here that it takes 25 minutes for your pain scale to finally get better, whereas morphine, you can see it just dives down right away. And so fentanyl works really fast. It's great for us in EMS. Morphine, by the time you get to the hospital, the pain finally goes away after you transfer care, and the doctor gets all the credits, right? That's, you don't want to do that. So that's morphine and that's fentanyl. So use fentanyl. And of course, the fentanyl intranasal dose is higher than the IV dose. Please focus on that. And then who knows how much dead space is in the MAD device? Some of you may know this. It's 0.1 ml. So look what happens if you have a 4-month-old who gets 0.18 ml. Well, 55% of the medication is now stuck in the MAD device. And so oftentimes, people don't realize that, and there are ways of getting around that, but just please be aware that the MAD device eats up a lot of medication. The 3-way stopcock eats about 0.3 mLs of medication. So these are some things that we've learned over the years that are important. Ketamine. I love ketamine for anything, everything, except that most of you carry the 505, which is 100 milligrams per ml. I akin that to a little espresso, right? It's very concentrated, and this is good for the IM or IN dose. For IV, this is like a cup of coffee, and you should be using the 10 milligram per ml. So you have a choice. You can either use 101 and then dilute it down in the field. I don't think you should do that. Or you should probably carry the 220, which is the 10 milligram per ml. And I think that we're going to be using ketamine much more for IV things rather than the IM excited delirium. So I would really I'm making a point here that this is one of the biggest issues with ketamine in the field, because if you give ketamine really fast, meaning that you don't give it over 60 seconds, you can cause laryngospasm. I think that's the biggest issue. So the other issue, look at the dose. If you use 100 milligrams per ml, the pain dose, which a lot of us are using for pain, you're going to give 0.05 mLs. Does anyone know what that is? I'll guarantee you that many people will make a mistake. When they drop 0.05, they'll probably drop 0.5. Even if you go to the higher dosing, it's only 0.4. You cannot give 0.4 ml for 60 seconds. It's impossible. So please go ahead and use a 10 milligram per ml dosing if you can. Seizure control, what do we use? So obviously there's some options. Let's remove the Ativan because it's very long acting and it takes longer to actually start. Between Versed and Valium, the diazepam for years was not good through intranasal route. It had a lot of active metabolites, so let's just remove that. And I think that most of us now use Versed. Versed's awesome because it's very fast. It's very fast on, it's very fast off. The only issue, it comes as 2 different concentrations, and the 5 milligrams per ml is probably better for intramuscular and intranasal use. So it's fast, you can use it at any route, it has very few active metabolites. You can see how fast in the yellow midazolam works. If you give it for a seizure, it just, boom, the seizure just is off right away. IN or IN. And you can see here that in a recent publication that they recommend using the non-IV routes and not using rectal route. So basically, go IN, go IM primarily in pediatric patients. That's the recommendation, and that's something you can do. So again, midazolam for IM or intranasal dosing, use the 10 and 2, which is 5 and 1, and double the IV dose. So that's something that I wanted to make sure of. You should do a doubling of the dose, so you're 0.2 per kilo IN or IM. Now you probably saw those 2 images and you said, who could that be? Like, is that someone we know? And it turns out it is someone we know. That happens to be Dr. Ken Shepke. Ken, are you out there? Gotcha. Okay, moving on. What about hypoglycemia? For hypoglycemia, Dr. Paul Rosikis from Oregon put out this great paper showing that all of your protocols look very different when it comes to dextrose. Why can't we just simplify it? Instead of D50, D25, and D10, why shouldn't we all just use D10, cradle to grave, 0.5 per kilo, max out at 100 mLs, repeat as needed, end of story. Okay, that's an easy one, right? This is the last one, fluid restriction. Should we restrict fluids for kids who are ill and potentially are tachycardic, maybe compensated shock? And as you know, that in the New England Journal, Dr. Maitland's article suggested that, and they basically said they recommend against bolusing children who are not in shock. But if you look at all these papers that ask, is there a benefit to withholding fluids? Only one little box showed a benefit, but the guidelines decided to put it in there. I don't agree with it. And so this is the study, it was called the FEAST trial. You guys surely know about that. This was done in children in sub-Saharan Africa, mainly with malaria. I don't think we've seen much of that here. That's the FEAST trial. Okay, and so what I would recommend, what we used to recommend is the push-pull method, 60 cc syringe, Three-way stopcock. That's the patient. There's to the IV bag, and that takes a while. You got to set it up. And so the other day we had the opportunity to explore a new device, which I think is really cool. And this is called a Life Flow. So you can give 500 mLs, so basically half a liter in about 2.5 minutes. And essentially you can give it to a 24-gauge catheter through an IO. So let's just play the video real quick, and then we'll see how that works. So basically you're just squeezing it. There's a 10 cc syringe in there. Every time you squeeze, you're giving 10 cc's, and it's pretty cool. So I think that's going to be a winner. And I'll stop there, and I'll take any questions. Thank you again very much. Appreciate it.
Repeat recommendation of hypoglycemia.
The recommendation is 0.5 grams per kilo.
Wait, what's the question?
Oh, repeat the recommendation for hypoglycemia. Use a D10 bag, which is 250 mLs, 25 grams total. You give 0.5 grams per kilo. If you want to know, that's 5 cc's times the weight. And then you max it out at 100. So the adult could get 100 mLs of dextrose, and you could repeat that as needed. Any other questions?
No, that was pretty. Thanks for the quintet of recommendations, Peter.
And all my slides will be up on the website.
Yeah. So the interesting thing is, okay, thank you. That's it. Thank you very much as usual. Okay.
Thanks.
So one of the reasons I'm really careful.